My topic are now the pulmonary diseases. And this is actually a huge topic. It's very broad. So I designed several scenarios, several situations, and I want to discuss these situations with you and some examples. So we start with the first one, and the first one is an acute dyspnoic, previously healthy patient. And this was, in this particular case, a 32-year-old man with increasing cough over the last weeks or days, but no fever. This was the chest X-ray. And if I see against this light here, I think you all agree with me that this particular patient had a more or less nodular pattern already visible on the chest X-ray. We did a corresponding CT, also showing you that the predominant finding are some nodules. Besides, the patient has some enlarged lymph nodes, and I show you some axial slices. And if we see on the HRCT the predominantly nodular pattern, the next question for the differential diagnosis is that we have to determine where are these nodules. And this can be much more easily done, sometimes in so-called thin slab maximum intensity projections, thin slab MIPS, to differentiate, are they sitting in a perilymphatic distribution, along the septa, along the fissure, for example, here is the fissure, or are they in a centrilobular distribution, in the center of the secondary lobule? None of these nodules is actually sitting along the pleura, or are they sitting in a random distribution? Some of them are sitting on the pleura, some of them are sitting somewhere else. In a random distribution, you would expect that you have an equal distribution. You have the same amount of nodules over here as compared to here. This is another example of this particular patient here with the distribution just on the axial slice and here on the maximum intensity projection. So I come to the first question after having you already given you some advice how you analyze the HRCT. And my question to you is, what would be your first differential diagnosis? Exogenic allergic alveolitis, sarcoidosis, respiratory bronchiolitis, infection, or organizing pneumonia? Of course, I threw into this differential diagnosis diseases which can be characterized by a predominantly nodular pattern. Please vote. Okay. Pretty widely spread. I just leave it. Most of you were thinking about exogenic allergic alveolitis and sarcoidosis, and the least was organizing pneumonia. I don't comment on that. I just go with you now through all this differential diagnosis. The next question is, did you see acinar nodules, perilymphatic nodules, paraseptal nodules, tree bud, or centrilobular nodules? And I have to admit more than one can be right. Remember that I just analyzed with you, are these perilymphatic, along the septa, along the fissure? Is this an equal distribution which we would expect in a random distribution? Please vote. Very good. Most of you voted actually for the combination D and E, tree and bud, and centrilobular nodules. And that was exactly the case and is correct. The findings are we have a diffuse, predominantly nodular pattern. None of them is actually really